Cu-Uvin will be talking to us about cervical cancer, death, and disability, a hidden public health problem in resource-poor settings. Take it away.
Well, thank you, Sharon, for inviting me. It's a great privilege to be invited for the Advanced Rhode Island CTR Clinical and Translational Seminar Series. And thank you also for the kind introduction. Sharon did ask me how I reached the level where I am and why I chose this kind of research area. And I must tell you that in the late 1980s and 1990s, I was an OBGYN and I was starting to see women with HIV, and there was really nothing much known about them. And I was very lucky to have Dr. Charles C.J. Carpenter, who was the chairman of medicine here at Brown at that time, who opened the first HIV in women clinic in 1987 in the US. So he was a visionary, and he knew that even if HIV/AIDS at that time was a predominantly disease of men who have sex with men and injection drug users, that women will be affected. So I came to train with him and I said, Dr. Carpenter, I would like to come to your clinic for 3 months to learn more about HIV in women because I'm seeing them and I don't know what to do with them. And after 3 months, he was awarded a CDC grant to look at the natural history of HIV in women. And this ran on for 10 years. And he asked me if I would stay within the HIV field as a fellow. And I went to my OBGYN mentors and they said it's the death knell of my career because they were all dying in their 20s and 30s. We didn't know how much mother-to-child transmission then was happening. And so women were being advised not to have any babies. And so my OBGYN mentor said, what kind of a career is that? So maybe out of naivety, stupidity, stubbornness, or I don't know, I told myself, when in my lifetime will there be a new disease that will happen in my lifetime and we don't know anything about? And so I said, yes, Dr. Carpenter, I will do the HIV fellowship for 3 years. And I think today I am the only OBGYN who has have 3 years of HIV fellowship. And that is how I got into this field. It's a zigzagging field, and for the early stage investigators, you never know what force come on the road for you, and just have the courage to do what you think is best for you and your career, not knowing what will happen. I could have failed. But you know, I was very lucky also being an obstetrician gynecologist. There was really not much investment in failure because I could always have gone back to being your regular obstetrician gynecologist. But this is the road I have chosen. And although my primary appointment is in the OBGYN, I've spent my 31 years here at Brown doing HIV work. So I many zigzags too. My first 10 years, I was more of a mucosal immunologist and virologist looking at HIV shedding in the genital tract, dynamics of resistance, mucosal immunology, doing phase 1 studies on microbicides for HIV and HSV. And then you get restless. And then I started doing a lot more global health work. And then I'm more doing a lot more in cervical cancer. So zigzag in your career, go where you want to do your career is. Wake up happy every day doing what you want to do. That's all I can say. So I'm going to start talking about cervical cancer, death, and disability. a hidden public health problem in resource-poor settings. Next slide, please. So at the end of this presentation, I am hoping that you will be able to describe the burden of global cervical precancer and cancer, particularly in resource-poor settings. As you know, there's very few cervical cancer in the US or in Western countries. Know the status of HPV vaccination in low middle income countries. List the recommendations of cervical cancer screening in low middle income countries and its limitations. And know the recommended treatment for cervical precancer or cancer in low and middle income countries to prevent cervical cancer. Next slide. So cervical cancer is one of the most preventable and treatable types of cancer. Yet, in 2020 and up to today, more than 600,000 women are diagnosed with cervical cancer worldwide, and 350,000 die from this disease, half of them. So the mortality is 50% all over the world. Screening and vaccination are key to prevent the disease. Next slide. More than 99% of the cases of cervical cancer are caused by an infection called human papilloma virus, particularly HPV 16 and 18, unless you come from different parts of the world where not only 16 and 18, but the series of HPV oncogenic viruses that are beyond 16 and 18, and particularly in women who have HIV. Vaccine exists that protect against carcinogenic types of HPV. In the US, we're very lucky. The only licensed vaccine now is the nanovalent vaccine, which covers 9 oncogenic HPV types to prevent our younger generation from getting cervical cancer. The problem is implementation and translation of this. We have an existing vaccine. It is 99 to 100% effective in preventing cervical cancer, and yet the uptake, even in the US, depending on where you are, varies very differently. So the overall uptake in the US is about 70 to 72%. But in some states and communities, it's as low as 40%. And I think we have problems about how we have communicated the vaccine. And many parents think that it's to allow promiscuity among their children because it's a sexually transmitted infection. And that is the message they're hearing. They're not hearing that it's a cancer prevention. And so we haven't been very, very effective in our messaging in some areas. And I usually try to ask the audience, in Rwanda, what do you think is the percentage of vaccine uptake? It's a low-income country. I'll tell you the answer is 99%, better than the US. So there are low-income countries that are doing better than the US. We have screening programs that can detect early signs of the disease, allowing time for effective prevention and treatment. Next slide. This is a slide showing the age-standardized world mortality of cervical cancer by all ages. And if you look at the United States and Canada and Western Europe, you will see that we have very low rates of mortality from cervical cancer. The darker the blue, the more likely women are going to die of cervical cancer, mainly in sub-Saharan Africa and in low and middle income countries. Next slide. And this shows you where, I'm sorry, the first slide was the prevalence. This red is where mortality is taking place. And of course, where there is more cervical cancer, especially in low and middle income countries, you expect more mortality. So it's the same regions with a high prevalence of cervical cancer, higher mortality. Next slide. But because of the natural history of HPV infection and potential progression to cervical cancer, it's one of the diseases where we really can make a dent in preventing cervical cancer. So if you get an initial HPV infection, 90% of men and women, those who get anal and those who get cervical, will clear the HPV infection. If you are immune competent, only 10% will have persistent HPV infection. And even if you have persistent HPV infection, if you go through screening and we find that you have cervical intraepithelial neoplasia 1 or CIN1, which we call mild precancer, many of you will still clear the HPV infection and CIN1. Then, if you neglect your care, over 0 to 5 years, you might develop what we call CIN2 or moderate cervical dysplasia or neoplasia. A few of you will still be able to clear it, but the majority without any treatment in 1 to 20 years will probably develop invasive cervical cancer. So there is always the outliers of, women who develop cervical cancer below the age of 35 or at a very later age. But this is the natural history. So we have a lot of years to intervene in women before they develop cervical cancer. Next slide. So what are the primary prevention? Well, we would recommend that boys and girls 9 to 13 years of age get primary prevention through HPV vaccination. And this, is the most important. The most important thing is the vaccine is not a therapeutic vaccine. It's a preventative vaccine. There are studies ongoing whether it can be therapeutic, but it's mainly a preventative vaccine. If you already have HPV 16 and 18, it will not eradicate it. So we start at an earlier age because we would like to prevent you from getting HPV before your sexual activities. And in many countries, it differs. In the US, I think the median age is about 17, and we would like to hit the vaccine before age 17. In low middle income countries with child marriages, it might be as early as 12. So we would still like to give it at 9 years of age. But you can go up to 26 years of age. And there are some studies that even up to 45 years of age. But I personally believe that once you have been very sexually active and you have had HPV, it's preventative, not therapeutic. Secondary prevention is women ages more than 30 who have aged out of the HPV vaccination is screening and treatment. So currently we have several methodologies, and I'm going to talk to you about them in the next slide. And tertiary prevention is for women who already have invasive cervical cancer. Depending on the stage of their cancer, they will need ablative surgery, radiotherapy, chemotherapy, or a combination thereof. Next slide. So, I have told you that HPV vaccines are highly effective at preventing cancer, but you look at this curve, and depending on how well we vaccinate, we are not going to make a big dent in cervical cancer incidence rates, depending on how well we vaccinate. If we don't vaccinate, the cervical cancer rates, cumulative incidence of cervical cancer continues to increase. If we vaccinate at 17 to 30 years of age, we decrease that. And if we vaccinate less than 17 years of age, we certainly make a very big dent, almost 100%, in decreasing cervical precancer and cancer. Next slide. But where are we in the target of 90% vaccination rate? We are very far from the target globally in males and in females. At the current average that we're doing globally, we are at about 20 or 30%, but not all countries are in that. Some countries are more successful than others. And we have a long way to go to target 90% for a global HPV vaccination coverage. So we have to really push and implement more HPV vaccination all over the world. Next slide. So protection from a single dose of HPV vaccine. For those of you who got it earlier, you had to get 3 doses. And now the recommendation is 2 doses. It's as good as 3 doses if you are immune competent. If you have HIV, we still recommend that you get 3 doses of the HPV vaccine. But there's a lot of excitement on the protection of a single dose HPV vaccine, which will make implementation a lot easier because the follow-up and coming back for a second dose of vaccine is really not great. Next slide. So a reduced dose vaccination is still highly effective in observational studies and randomized cohorts. So if you look at these numbers, you will see that even if you give only 1 dose of the vaccine, you have great protection against HPV 16, 18, the other oncogenic viruses in red, and other carcinogenic viruses compared to 2 and compared to 3. That is a very good data. Next slide. Oh, I'm sorry, maybe I'm missing a slide. The effectiveness of a single dose on the short term is as good as 2 doses or 3 doses. The big question is, how long will this immunity last, and will we need boosters if you only got a single HPV vaccine? But I think in some countries with limited access to vaccine, there's no excuse by saying we don't have enough everybody for 2 doses, so we're not doing it at all. I think they should be encouraged to just start even with a single dose of vaccine. So what are the screening modalities that are available in low-income countries? Visual inspection with acetic acid is the most prevalently used in low-income countries because it's cheap and it only needs a GYN capability and household vinegar. The pap smear, you're all familiar. I think many of the audience, if they are females, have undergone a pap smear test. And for high-income countries, we do that with co-testing with HPV testing. And then I think this week or next week, the U.S. Public Health Task Force will be coming in with a recommendation of using primary HPV DNA testing, self-collected or clinician-collected, as the primary mode for women 30 and above. So you might not even need to see your gynecologist anymore. You'll just get the swab and send it to a lab, and only those that are positive for oncogenic viruses will then have to come back for further testing. So many studies have shown that it is reliable, high sensitivity, good specificity, and the clinician versus the self-collected swabs are as good as each other in getting enough DNA for processing. Next slide. So if we're going to a low-income country like Kenya, Bangladesh, Nigeria, Pakistan, and other low-income countries, we use visual inspection with acetic acid. So you do a GYN exam, you put in the speculum, you expose the cervix, you take away the mucus with a cotton swab, and you put in household vinegar on the cervix for 1 minute. Then you take away and you will see whether you have a normal cervix or not. A normal cervix will show you equally pink all over, particularly in what we call the squamocolumnar junction, which is that hole in your cervix, we call the endocervix, and the surrounding bigger part of the cervix, we call the ectocervix. Like all cancers develop in the area where there's growth of cells. And to make it easier anatomically, the transformation zone is almost equivalent to what we call the squamocolumnar junction, where you have the division between your endocervix and your ectocervix. That is where new cells are being developed, and those are the ones that are being infected with HPV, and those are the ones that will undergo dysplasia to become precancer or cancer. So after putting your vinegar, if you see this kind of cervix, it's a normal cervix. Off they go. Then, next slide. If you put your vinegar for 1 minute and you see this white thickened areas all over the transformation zone or your squamocolumnar junction, extending even to your ectocervix, this is what we call VIA positive. It doesn't tell you whether it's CIN1, CIN2, CIN3, or invasive cancer because it's visual. It's not histologic. But then these are the women that should undergo colposcopy and biopsy to see what cervical neoplasia they have. Next slide. Now, the one on the left side is again VIA with acetic acid, and you can see abnormal areas that are staining white and thickened. And the one on the left side is where we use Lugol's iodine. Lugol's iodine, if you have a normal cervix, should all be mahogany brown, except in the endocervix, which is lined by single columnar epithelium. So as you can see, the mahogany brown cervix is not all mahogany brown. There are areas in your 12, 11, and 10 o'clock where you have yellowish areas. And those are abnormal areas. That is a positive VILI or visual inspection with Lugol's iodine. The bigger portion of your yellow is not abnormal because that is your endocervix. That is the single columnar epithelium that will stain yellow. So you need a lot of teaching on how to do VIA and also a lot of refresher course because VIA is very subjective. Next slide. When you see this, of course, a meaty, eroded cervix with a lot of bleeding, and believe me, you can smell it right now, but if you were there in person, it's rotten meat smell. It's like a rat died right in front of you. And that is already suspicious for cervical cancer. Next slide. So in low-income countries, what do? We screen with visual inspection with acetic acid. If it's suspicious for cervical cancer, they undergo biopsy. If it's VIA positive, We will determine whether we can do what we call a see and treat, where we see the patient and we are able to treat them immediately, because loss to follow-up is a big problem in many settings. Who are eligible for cryotherapy or thermocoagulation? The ones that are VIA positive, if they're eligible, the abnormal area has to be less than 75% of your transformation zone. There should be no abnormal blood vessels. They should not go, the limit of the margins of what you see should not go inside the endocervical canal. And there should be no satellite lesions, meaning scattered lesions that are away from each other. Those are eligible for cryotherapy or freezing or thermocoagulation or burning. Luckily, the cervical nerves, you can cut it, you can burn it, you can freeze it. There's minimal pain, unlike any other parts of the body or even the vagina, for example. The vagina is not like the cervix. It has a lot of nerve endings. Those who are not eligible for cryotherapy or thermocoagulation should go for colposcopy, biopsy, and be treated with what we call loop electrosurgical excision procedure. And we usually do a post-treatment follow-up of 1 year. Ideally, we would like it 6 months, but there's a lot of no-shows. So we have to do a lot of calling and contact tracing. So we extend it up to 1 year. Next slide. So I want to talk to you about some of the cervical cancer screening that we have done in the world. And in Bangladesh, cervical cancer is the second most common cause of cancer death among women, with a staggering 12,000 new cases each year, and again, 50% deaths from cervical cancer. In 2019, Health and Education for All, an NGO, has been trying to develop a one-stop see and treat cervical cancer screening program in the 9 sub-districts in collaboration with the government of Bangladesh to improve cervical cancer screening awareness among over 50 million at-risk Bangladeshi women. And let me tell you that Haifa, USA is led by our very own Dr. Ruhul Abid from the Division of Cardiology here at Brown. So I work with him a lot. Next slide. So because of the work that we have been doing, Dhaka Medical Center developed a cervical cancer screening and training research center that was inaugurated in 2023 that now provides 2 weeks training of doctors, midwives, and nurses to do cervical cancer screening. And because before that, for our grant that was funded by the UNFPA, a branch of the United Nations, I was doing all the training and the retraining for the midwives, the nurses, and the doctors. And now there's a national cervical cancer screening and training research center. Next slide. So why did we want to do a UNFPA sponsored grant in Bangladesh? It's not because they were not doing VIA. They were doing a lot of VIA. But the report, when we looked at it, is that many of the VIAs that were being called positive, which is the blue bar, 48% of them on colposcopy or biopsy turned out to be normal, which means the sensitivity and the specificity of the VIA was extremely poor. And so we said, is there a better way of doing VIA to lessen this false positives. 48% false positives, like it's a toss of the coin. You might as well just, just flip a coin and say you're via positive or you're via negative. Next slide. So we applied for a UNFPA grant, which was luckily funded. It ran for 3 years because we were delayed when COVID hit. And we said, how about we use a mobile colposcope, and maybe we can improve the naked eye image using a mobile colposcope that can magnify what we are seeing compared to the naked eye. It also can collect the data of all the patients. So instead of paper data registering and everything, we can do it all with one instrument. And then we can do a picture before we apply the acetic acid and after we apply the acetic acid. We can take multiple pictures and it's touch sensitive. So you don't even have to click anything. You just put your arm in front of this machine and it will take a picture. And because it's digital, you can make as many pictures as you can and delete the ones that you don't have. It also has cloud storage capabilities. So because of the 10 to 12 hour time difference between Bangladesh and here, I can look at all the slides and pictures, and I can tell whether it's via positive or negative, whether we concur with the doctors and nurses and the midwives, and who will go on then for treatment or further biopsy or treatment with lead. Next slide. That I forgot that mobile colposcope now has also AI capabilities because it's been capturing all pictures, more than 1 million pictures of via positives and corresponding histology, whether they're CIN1, normal, 2, 3, or invasive cervical cancer, has now AI capabilities. And within you upload your pictures, good pictures, and within 60 seconds, it will give you a reading, whether it's via positive, whether they think it's more CIN1 or CIN2, or it's suspicious for cervical cancer. At the time that we were doing this, that capability was not available for us, but the newer version of that mobile colposcope now has AI capabilities. So I don't even have to do it in the cloud anymore. The only problem for low-income countries is it's expensive. You have to pay $3,000 a year subscription to get the AI capabilities. Anyway, this next picture is the thermocoagulator. Remember when I told you we want to do a see and treat program where if we find that you're eligible for ablation, we would like to thermocoagulate and treat your precancer, mild precancer before you leave, because finding you to come back and bring you all over again, particularly women from rural areas who have very little finances or transportation problems, are not going to come back. And thermocoagulation and cryotherapy has been known to be very effective in treating mild precancer. Next slide. So we have screened more than 70,000 women ages 30 to 60. And when I submitted the grant, I also asked the government an exception because the national guideline is 30 to 60-year-old women to be screened. But what I learned when I went to Bangladesh, and especially in the rural area where I wanted to work with, child marriages were very common. And they start at 12 to 13 years of age. So they're sexually active. They're being exposed to probably HPV before age 30, more than 10 years. So the government of Bangladesh allowed me to screen women who are less than 30 years of age, but have been married for more than 10 years. So that is how we designed our VIA project. Next slide. So the upper left corner is the whole map of Bangladesh. And the dark part is Kurigram. When Dr. Abid and I were designing this project, my only question to Dr. Abid is, where is the poorest district of Bangladesh where there is no cervical cancer screening happening as a standard of care? He said Kurigram, but nobody wants to go to Kurigram because it's at the border of Nepal and India. It's the poorest district of Bangladesh. So the bigger map that you're seeing is Kurigram. And this is where I chose to do the work. And you will see a lot of rivers cross into Kurigram. And we cover all sub-districts in Kurigram. And the problem is in some of the areas in the lower part where the three tributaries of all the melting glaciers from Nepal, Bhutan, and the Himalayas and India, when it's the summer, floods the whole of Kurigram, particularly the south. And some of our areas, we can't reach them for 3 months because they're totally flooded. Next slide. So how do you begin a successful cervical cancer screening program in a very rural area? The backbone is peer navigators. So you need to find women in the community that can talk to their peers in the community. We spend a lot of money training peer navigators who speak the dialect, who speak the same language, who live within the communities of the women that we are reaching. And they do a lot of the education on cervical cancer. We have cartoons, we have flip charts. Dr. Abid and I went on radio with translation. We went on TV. We have videos and everything. But you will never be successful without translation, without education. And that is the whole basis of any grant if you're going to do it in the community. Next slide. And you also have to improvise because unlike here where we have GYN tables and we have, the clinics and everything, we had to start from scratch. We had to go to the market to buy GYN tables, the stirrups. You can see the mobile colposcope there that is already set up. We had to go to the market to buy buckets. I had to teach them how to sterilize their instruments, from cleaning it up with soap and water to soaking it in Sidex, again to cleaning it up with distilled water, because we don't have autoclaves in the field or even in the sub-district hospitals. And then and Saim, our program administrator, has to be commended for developing this tent. We are dealing with Muslim women in rural areas who are very, very modest, who deliver most at home, who have never had a GYN exam. And not only do they want the area covered both sides and the back, but they also require the covering of the tent at the top, even if nobody can see the top. But that's just how modest they are. So you have to know your patients too. Next slide. This is a trained nurse who is now doing the colposcopy in Kurigram and in Cox's Bazar, where we have expanded. Next slide. But sometimes women cannot come to you. You go to them. And like I said, Kurigram is all rivers. And I learned a lot too there, that there are migrant communities where we call the chore communities. So during the dry season, the water ebbs and you have these islands where people go and live there. When the flood comes, these islands disappear and they all disappear into the upper parts of Bangladesh. So there are temporary communities. And so we have to go and reach them at low tide, and we take boats. And these are the boats that we take. So I fly from Boston to Dhaka, which is about 16 hours. And then from Dhaka to Saidpur, which is about an hour, a 3-hour ride to my base in Kurigram, 1 to 2 hours to reach our sub districts, and then sometimes 2-hour boat rides to reach the other areas where we do our cervical cancer screening. Next slide. This is us. We have to bring our whole team because we don't have any capabilities without bringing everything. And you can see that we have no life jackets. We take this on face value. We ride these boats, wooden boats, with our life jackets because but at the end we provided life jackets to our personnel, but you always learn what is missing. Next slide. We cross temporary bridges because there are many rivers there. And sometimes we have to walk 1 to 2 miles to reach our patients. Next slide. We have to hire, they tell me this is a horse. It looks more like a mule to me, but we have to hire a cart to bring all our supplies. Next slide. But we are so hardened that sometimes in our camps, over 100 women come and register for cervical cancer screening because of the success of our peer navigators. And we work from morning till night. We don't leave until we finish all the women who come and register for this. And I had to change the culture a little bit because they're used to having a snack in the morning, a long lunch, a snack in the afternoon. And I must have appeared like a slave driver because I said, I'm not taking your snacks away from you or your lunch away from you. Don't worry about me. I can go on the whole day not eating, but you have to take turns. Next slide. So what did we find? I will skip some of the slides, but I will go to the last slide. Next slide. One more. Oh no, go back. So if you really know how well the VIA with mobile colposcopy with biopsy is doing, poorly. The real VM positives, when you do a biopsy, is only about 2%, despite the mobile colposcope, despite training and retraining. Why? Because over 70% of the women have cervicitis, and they look like VIA positive or VILI positive. So this is one lesson we learned. A very high rate of cervicitis will interfere with your VIA, even with the mobile colposcope. And the biopsy is the gold standard, of course. Next slide. So this is just to tell you again, just another graphic representation that if you're working in an area with high cervicitis, your VIA, your VILI, even with the mobile colposcope will not be reliable. Next slide. However, we did find 25 cases of cervical cancer. We provided treatment support for 19. 3 of them wanted holistic medicine and didn't want to be treated. 3 died because they were too advanced, but we saved 19 women who were treated with ablative surgery, chemotherapy, and radiotherapy. So I think I consider that a success in an area where nobody has been screened for cervical cancer before. Next slide. Anybody recognize this? This is the Rohingya camps. 1 million Rohingya displaced people from Myanmar descended on Bangladesh, and they had to be accommodated. Next slide. This is our clinic. We have 2 clinics. Brown has 2 clinics in the Rohingya camps. They are containers, and you can just see that we just made slits for windows. Next slide. This is our team. Next slide. I can tell you that I always learn. Because we had success in Kurigram, we also did the cervical cancer screening for the Rohingya forcibly displaced Myanmar nationals. And on my first day there was a whole line of women. But after I finished 2 women, the line disappeared. And I said, what happened? They all decided they didn't want it. And we had peer counselors. We talked to the peer leaders and everything. My lesson, we didn't talk to the imam and we did not talk to the husband. So in each different community, there's a different hierarchy and women empowerment. In Kurigram, the women were empowered. They were farmers, they were entrepreneurs, even if they were housewives, they were Muslims, but they were empowered. In the Rohingya camps, there's a hierarchy of empowerment. And you have to talk to the imam. The imam will talk to the husbands. The husbands will then allow their wives to have a GYN exam or not. Next slide. I'm almost done. And in Kenya, we did the same. We started with 1 clinic in 2009. We are now up to 11 clinics. Next slide. We started with 1 room. Again, I started buying supplies and everything, having to teach everybody, teach autoclave, bought all the supplies in the market. Next slide. Now we have a cancer center, and from 1 room to a whole cancer center. So this is not because of me, but it's because of a lot of people working on all different types of cancer. But cervical cancer was clearly one of the first impetus for acknowledging cancer in that area. Next slide. We have now, I think this is 2022 or 23. We have screened over 190,000 women, both HIV positive and both HIV negative. Next slide. I am not going to overemphasize to you that, if you're HIV infected, you have a lot of HPV, and even undergoing cryotherapy or loop electrical surgical excision procedure, if you're HIV infected, is not as effective as when you're not HIV infected. Next slide. So next slide. So this just shows you high persistence of high-risk HPV among women who have undergone LEAP for CIN2 and 3 because they are HIV infected. Next slide. This is the WHO current guidelines, which has now gone to HPV screening, both for HIV positive and HIV negative women. The data there for HIV infected women is not very strong. Next slide. Self-collection, like I said before, is now FDA approved. Next slide. So in summary, low and middle income countries bear the biggest burden of cervical cancer. HPV vaccination is highly effective. HPV testing is the most effective cervical cancer screening method. Women with HIV have higher prevalence and persistence of high-risk HPV. LEAP is more effective in treating CIN among women with HIV. Next slide. Next slide. I just want to thank my team, both in Bangladesh, next slide, my team in Kenya, and also the Advanced CTR for giving me this opportunity. Thank you so much.
That is really terrific. Thank you so much, Susan. So we have a question in the chat. What's the percentage of women above 13 years of age who are vaccinated with HPV vaccine in the United States? And a follow-up question is, I understand that Rhode Island is doing a really good job with this. Can you tell
Yes,
us why
I'm
and how?
very proud of Rhode Island because we are in the 90%, but the rest of the United States overall is about 72%.
72%.
Yeah.
So Rwanda is doing a lot.
Rwanda is 99%. It's a small country. It's almost like Rhode Island numbers, easier to do than
That
many
that
bigger states.
it's really very impressive work. So it seems to me that these peer navigators might be useful in the United States. Has that
Yeah.
been done in this country, and
Oh,
do
yeah.
they have the same effectiveness?
No, I think the United States is very heterogeneous in different places. We have some very conservative communities. There's no amount of peer navigating and explaining that's to save them from cancer instead of making their children promiscuous because we have an STD vaccine. And I think we will never convince those. I'm a bit worried about our new leadership for this vaccine mistrust. So, but the US is so huge. It's very different communities. But for example, during COVID, peer navigation in Central Falls and Pawtucket was the most effective for convincing people to get their COVID vaccine. So it the US is just so heterogeneous that it's hard to do a blanket statement on it.
Okay, very good. And I guess, what's going to be the future with these this work in the low and middle income countries? Does the United Nations fund this work? Are there international organizations that will?
Yes. We keep scouring. I mean, Ed is here. Ed will probably tell you there's never been a grant opportunity I did not like. We look at the Bill and Melinda Gates Foundation. We look at the Wellcome Trust. We look at UN. We look at every possible because there's a lot of competing uh, you know, diseases or health problems in low and middle income countries. And, no matter what, infectious disease is very high up there, but HPV is not really one of the infectious diseases that they're looking at, TB, malaria, you know, um, cardiac disease, you're competing with so many. And so we keep on scouring grants where we can insert ourselves in, but money is hard. Grant writing is hard. Getting funded is hard. I want to say that, but it's so rewarding. There are more failures in my cabinet of grant applications than the ones that are funded. You only hear the ones that are funded, but I can tell you, I have a full cabinet of unfunded grants.
Another comment from the chat, we have a very high prevalence of cancer in Uganda.
Mm-hmm.
And the numbers are burdening the cancer treatment centers. And the comment is, I think this extensive screening is necessary to ensure that cases are detected early so that treatment is also initiated early. Have you thought about extending this program to other low and middle income countries, including Uganda?
We are working in Uganda. We have a U54 with Kenya and Uganda, where a lot of cervical cancer screening. We partner with Makerere University. So we are doing self-collected swabs and see and treat treatment programs in Uganda. So
And
it's happening.
I believe I read in the New York Times, like very recently, that the FDA has recently approved self-collected.
Yes, it has.
So that
A
will make,
couple of weeks ago, Sharon.
yeah, okay, not too long ago.
Not too long ago.
Wonderful. So that will make, hopefully relieve some of the obstacles, at least.
But we have implemented it in low-income countries much before it got approved in the US.
Oh, that's
So
interesting.
sometimes low and middle income countries are ahead of us uh, in many ways. Like community HIV testing, for example, which is not acceptable in a very individualistic, HIPAA-laden infrastructure in the US, can never be done. But community testing or family testing of HIV has been done in low and middle income countries for many years now.
Okay, great. Well, thank you once again. This is really inspiring, and it's great. It's really terrific to see the resilience and cleverness and that required to bring these treatments to remote spots like in Kurrigram. It's really great. And so we'll close there, and everybody fill out the survey, please. And thank you and next month we have Ari Pelkovitz and Patty Sullivan presenting on indolent lymphoma and the tumor microenvironment. So, and then on a second talk on exploring the heterogeneity of chordoma. So anyway, that's next month. Merry Christmas, everybody.
Merry Christmas, everybody. Happy
holidays.
holidays. And thank you so much for this privilege of giving this talk.